this muscle is not replaced as a muscle tissue, it is being replaced as fibrous tissue, which is not having enough strength to hold or do any perform any movement in the joint. That is the problem with children with the Duchenne muscular dystrophy.
Sorry for the interruption. So your PowerPoint is not moving.
Oh, one second, it will move. Just I'm giving overview.
Okay, it's okay, sir.
So that is a standard. One second. Just the next slide. It's not going. Next slide is not going. Huh?
Slide share. Slide share. I mean, Google.
One second, Eva. One second. Next, how to move to the next slide? Okay. 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 So that is a problem with Duchenne muscular dystrophy. Hello, am I audible, Dr. Thamani Silver?
Yes, sir. Very much audible.
Yeah. So as I said, because of the absence of protein, this dystrophin, muscles, whatever muscles, it goes for degeneration. Wasting, it is not being replaced as a muscle tissue because of the absence of the protein. So what we do, what is the present standard of care for children with muscular dystrophy? Because there are more than any individual with a suspicion of muscle disease. When a parent brings a child that my child has difficulty in getting up, frequent fall, and there is a big muscle in the calf muscle, and there is the child milestone is less than, then we have to suspect. After ruling out neurological disorder, once when we thought of any neuromuscular pathology, earlier 30 years back, we are not aware of all these molecular diagnostic facilities. Only option is doing a muscle biopsy. Now, thanks to the advances in the molecular diagnostic facility, wherein when we have a suspicion of muscle disease, initially we thought it is a muscle disease. That is called phenotyping. To give a correct name, that genotyping, there are various options available now. It started with the PCR. That is a simple test which used to be done 15 years back. But the problem is it could able to see only few exons. Then the next advances has come, MLPA, multiple ligation probation assay, which in turn will try to give much more exon deletion, exon 40 or exon 41 or whatever it may be, it will tell. Now the molecular diagnosis advanced further. There is a technique called next generation sequencing, wherein it could able to read almost all the complete gene, and it is a valid thing for the neurologist clinician to come to a conclusion. Okay, this is a clear muscular dystrophy, because in PCR only they could read only few gene. In MLPA they could only read few gene. Now this next generation sequencing is as a revolutionized the diagnosis of children with Duchenne muscular dystrophy. One. The second is once when the NGS is not supporting the child has got Duchenne muscular dystrophy. Now a new technique called whole exome sequencing has come, wherein it could able to identify the further classification of any muscle disease like a Becker or spinomuscular or congenital myopathy types like Nemelin or limb girdle muscular dystrophy or hereditary sensory motor neuropathy, because there are more than 64 genetically proven dystrophies are there. Among 64, 9 is common. Among 9, Duchenne muscular dystrophy is the commonest prevalent muscular dystrophy throughout the globe. But the present statistics, what I say, is confined. It is a global statistics, but unfortunately, we don't have any national statistics. If we really work on national statistics, it could be much more, because our population is more and the consanguineous marriage is more common in our Indian population. We also now tied up with ICMR and the National Disease Informatics Center in forming a registry, so that we could able to bring more awareness about muscular dystrophy to the entire country. Even in our practice, we see once when the child has some suspicion with the muscular dystrophy, child who got access to all the diagnosis Over in metro city, they are diagnosing it earlier, and the next child, before they have the next child, they do career counseling to find out whether that mother is prone for the next child also is prone for muscular dystrophy. Appropriate intervention being taken. In other states, even like the states and other cities where there is no enough medical facility, by the time they come to a conclusion that the first child is diagnosed with Duchenne muscular dystrophy, they will have 2-3 child. The entire family, entire siblings will get affected with the Duchenne muscular dystrophy. It is a very big burden for the parent to manage 3 children with a disability, and for the entire, it is not an easy thing for any parent to have 2 to 3 child with the Duchenne muscular dystrophy. So the main purpose of the meeting is, one is early diagnosis is very important. That through our association, central government NIPMED association, your association which is under the Ministry of Social Justice Empowerment, if you could able to impart this knowledge to the various part of the our India, they will be in a position to come to their doctor for a correct diagnosis. Then appropriate intervention will be taken to prevent further children with the Duchenne muscular dystrophy. So, as Dr. Maruti says, the management of Duchenne muscular dystrophy is a teamwork. Initially, a child will go to a pediatrician. Pediatrician, when he suspects the child has got some issue, he will refer the child to a neurologist. Neurologist will do neurological evaluation to rule out whether the child has got any developmental delay or any cerebral palsy or any other brain or spinal cord disorder. Once that been ruled out with the MRI scan, X-ray, and the CT scan and nerve conduction test, then they will suspect whether the child got a neuromuscular disorder. It will be revealed with a simple muscle enzyme test, CPK. When there is an elevation in CPK, it shows that some muscle damage is there. Then they will do this genetic testing to come to a conclusion. That is the role of a neurologist to conclude what type of muscular dystrophy is there. Once when the diagnosis is made, then the team will come, starting from physiotherapist, occupational therapist, speech therapist, orthotist, and a psychologist to manage these children with Duchenne, muscular dystrophy. Among that, I'm just going to tell in brief about what basically physiotherapists do, because all the experts are here available now. You'll be knowing about your role in management of muscular dystrophy from a speech therapy point of view, occupational therapy point of view, psychologist point of view. From our physiotherapy point of view, what they say, physiotherapy input is very essential for the maintenance of muscle function in DMD. The main focus of treatment is to slow the disease progression, control secondary conditions, improve the quality of life of the patients and the family with the disease. As you all know, when the child been diagnosed with the Duchenne muscular dystrophy, in the initial 5 years, there is no major medical intervention being made by the neurologist. All the intervention based upon, there are certain outcome studies available. So as I said, initially investigation will be made, diagnosis, after they classify the muscle disease, clinical and physical evaluation, and then management will be medical and rehabilitative, along with the physiotherapy, appropriate provision of orthotics and wheelchair, and also we can't leave their educational needs because all these children are intellectually fine. Only thing is a physical disability. You have to look for the alternate ways of educating them, and most importantly, they need a proper follow-up. So, as I said, the patient with the Duchenne muscular dystrophy, they need it is a team approach. Diagnosis important, rehabilitative management, cardiac management, pulmonary management, nutrition management, orthopedic and psychosocial management are the main key. So, with regard to evaluation, if you have a child or adult with any illness, there are a lot of outcome studies available. Supposing if you have a person with a diabetes, once when the doctor diagnoses diabetes, they will start on either medication or injection depending upon the type of diabetes, with regular follow-up once in 3 months, 6 months, or whatever the doctor is comfortable. There are hematological values to see the outcome of the disease, whether with the medication the disease is under control or it is going bad or it is going down. Depending upon that, what doctor does, they alter the medication, they advise further test or any other intervention is possible because it's been proven in the case of diabetes and other condition. But in the case of muscular dystrophy, there is no hematological or a diagnostic test available to see the progression of the disease. So the most important thing is physiotherapeutic evaluation plays a major role. Once any doctor diagnoses a child with Duchenne muscular dystrophy, at the earliest, he refers the child to the physiotherapist. What we do, basically, most of the time we see the child after 5 years. If the child referred before 5 years, we tell the patients, don't worry about physiotherapy or any other therapy now. You strictly follow what your doctors say. At any cost, don't overdo any activity. Some people, some parents are very keen. No, doctor, I would like to take my child for Ayurvedic massage. I want my child to walk 2-3 kilometers. I want my child to do half an hour cycling. I want to, do various activity for my child. They will come and tell. What we will suggest is, see, this is not a neurological or a developmental disorder. This is basically a neuromuscular. If you start working on too many activities, when the muscle goes down, your child will become non-ambulant at the earliest. Let the child do whatever activity possible. Don't force the child by doing excess activity. Give the child proper nutrition and ensure that the child got a balanced diet to maintain ideal body weight. More the weight, again, there is a strain on the muscle. Muscle will again go for wasting, and it can't be replaced with muscle tissue. There will be a further deterioration. For all those things, so what we do, we start doing documenting the child strength with respect to muscles, function, pulmonary, everything we used to measure. So these are all the commonest tool we use in our clinic. One is manual muscle testing. When we do manual muscle testing, the grading are between 0 and 5. When I grade a child with 4, that is against the gravity with the maximum resistance he can hold, my resistance will be different with what Thamari Selvan does or any other therapist does. So we need to have a quantitative strength. Supposing if there is if I want to strength just the biceps muscle, I want to have a quantifiable value that will help me in guiding how the child progression, how the child is deteriorating. For that, what we use equipment called handled myometry to see the quantitative strength of major group of muscle, which is one of the main outcome. And the next is we use a JAMA dynamometer to check the grip strength of the child. The third is the most, as I said, all the skeletal muscles will slowly go for degeneration. It is so for the pulmonary and cardiac muscles also. When the child grows, because of the asymmetry, in the sense when the spine goes for little bending or when the muscle is not working properly, the expansion of the lung also get little compromised. What we do once when the child is perform, yes sir. Perform pulmonary function test, we do frequent pulmonary function tests to measure the functional vital capacity, check the strength of the diaphragm and the respiratory muscle using a gadget called MIP and MEP, maximum inspiratory and maximum expiratory pressure. And then we do timed test. One of the most important tests now being used in the clinic global wise is 6-minute walk test. 6-minute walk test is one of the main strong outcome tests which is being used in the clinic across the globe to check the disease condition and how the child could able to perform, how many meters the child could cover in 6 minutes with a standard instruction that we will document it. And one more golden standard test is North Star ambulatory assessment. It checks the child performance from how the child is getting up, standing, walking, and all the parameters are around 17 parameters will be tested. Out of 34, when a child performance goes less than 29, that is the ideal time for the clinician to start the child on steroid tablet. Before that, the clinician won't start with the steroid tablet, because when I was in UK, they used to say, "Oh, you Mr. Edward, your North Star ambulatory assessment has come to 26. Now this is ideal time that I need to start you with on a steroid. You be regular with this steroid. So these functional tests like timed test, North Star ambulatory assessment, all plays a major role, give a clue to the clinician to decide upon when to start the medicine, when to increase the dosage, when to work on other parameters like how to have an eye on respiratory, how to in what way they need to have eye on cardiac function, all based upon the clinical evaluation, what been standardized globalized through our network. See, I am part of international research group. There are 14 centers across the globe. We work on children with muscular dystrophy. How these standards are made is we work with the person who is instrumental in isolating the gene dystrophin. He started a group called a CINRG, Cooperative International Neuromuscular Research Group, wherein we 14 centers across the globe been identified, and there is a investigator, a neurologist, and a clinical evaluator, physiotherapist. The investigator will be trained in how a child to be diagnosed. There are certain protocol which needs to be followed globally. Then the evaluator will be trained to do a uniform evaluation so that the outcome will be standardized across the globe. Then what we did, we worked on identifying children with Duchenne muscular dystrophy using standard diagnostic criteria. At that time it was MLPA. Then we we divided the children in various age group between 1 to 5, 5 to 10, 10 to 18, and above 18. What we did a natural history of the disease for 5 years. This study been sponsored by University of California, Davis, and the National Institute of Health. We check the child between 3 months, 6 months, 1 year, 2 year, 3 year, 4 year, 5 year. All the aspects will be evaluated: muscle strength, cardiac function, pulmonary function, psychological, digestion, speech, swallowing, all the parameters across the globe. There is one central station wherein all the data will go, that is in Children's National Medical Center, Washington University. After 5 to 7 years, all the data they have analyzed, then they found at what ages, what changes happening for these children with the Duchenne muscular dystrophy. Okay, this child normally walks on a normal, have difficulty in getting up. Between this age, started walking on toes. Between this stage, the child goes to wheelchair. Between this stage, this goes to bed phase. And what is the other uneventful events happening? All those things we have some idea. Same
So
thing we measured.
one second, sorry to interrupt, sir. Yeah.
Yes,
Sir,
yes.
I think your slides are not moving. You're just
Yeah,
explaining.
this is the explanation for
Explanation only.
Yeah. So
Oh.
based on that, what happened? So based on that, what we know with all these details, we got now we have enough data to support what measurements are needed. Because when I was a student in in the government college and all, when a patient has any problem, only they'll come to the doctor. Now this natural history study has given us some idea what intervention to be given at what interval, so that the quality of the life and the longevity of the child will improve. So this is the basic evaluation what we do. Now I'm going to tell, because the reason why I told was how we set up a standard of care for these children based on our original follow-up of children for 5 years across the globe, seeing what changes happening in the system, and proactively what intervention we need to do to minimize or prolong the complications. Among that, this is the gist of our entire idea in setting up a standard of care. My topic is on standard of care. The standard of care was set based on the natural history of the study. Then we work as a team in setting up standard of care. One, from the physiotherapeutic point of view, as I said, there are various tests available, from manual muscle testing, quantitative muscle testing, North Star 6-minute walk test. Each and every clinic uses different evaluation, but commonly, the previous slide what I showed, these are all the commonest evaluation being used in the centers to assess a child with Duchenne muscular dystrophy. So apart from that strength testing, we also check the activities of daily living. We have two type of questionnaire. One is a patient, and another is clinician. Patient means the patient self, it will tell that what are all the difficulty he has, or as a clinician, we will ask the parent or the child to tell about the difficulties. Based upon the questionnaire, we will be in a position to set up what type of intervention the child needs. So what we basically do, the child has come with a problem, the clinician evaluated, diagnosed what type of dystrophy using this molecular diagnostic testing. Then initial few days, the child was allowed to do normal activity. Once when the child Doctor ambulatory assessment scores goes down, then it will be referred to the physiotherapy department. When as a physiotherapist, I will do all the tests as what been listed in the previous slide. Once when I know that once after I documenting all the evaluation, then I work on physiotherapy. What type of physiotherapy is advisable for these children? One is, as I said, these children doesn't require any aggressive or strengthening or any resistive exercise. They basically need stretching, because because of constant firing of anti-gravity muscle, the child will come with tight Achilles, tendo Achilles. The child will come with a tight hamstring. The child will come with the tight hip flexors. The child will come with a tight iliotibial band, pronated forearm with little flexed wrist. What I do, muscle exercise. This basically helps because inactive can make the disease worse. We have to activate the muscle to a possible extent. One is it maintains the flexibility. Also, we help in setting, advising braces or wheelchair. Also, these measures will help in leading a child to have a better quality of life. What sort of goals we set in? The goals what we set in is to maintain good range of motion and symmetry at a different joint, to maintain best possible function, to prevent any deformities or contracture. Also, we have to aid in standing and walking. So as I said, the only fourth thing, if in my entire lecture, if the audience could able to take these 4 points, that is more than enough. One is, as with the prevailing tightness in the 4 group of muscle, main is stretching. We teach the parent how to do proper stretching of Achilles, hamstring, iliotibial, hip flexor, whole arm. That stretching to be followed at least 5 to 10 repetition, holding for 10 seconds, 2 to 3 times a day. Then range of motion to maintain the flexibility what they gained out of stretching. Entire joint range of motion, no weights, no resistance, just 20 to 25 repetitions will do. If you do more movements, there is a chance for the muscle to damage. Unfortunately, there is no dystrophin. It won't get replaced as muscle tissue. There will be further deterioration in the muscle power. Next is positioning. As you all know, the child tend to have plantigrade position in the foot. So position the child with a good ankle foot orthosis so that we can minimize the tightness of the Achilles tendon. Another thing is, this child may develop tightness in the iliotibial band, so pillow on the side to keep the leg in straight position, and proper breathing exercise. These children, with the weakness, they start doing trick movement using accessory muscle. Train them how to use the proper diaphragm intercostal, that too with minimal repetitions, not more than 5 to 10 repetitions. So these are all the various type of stretching. As a physiotherapist, most of the physiotherapists in the group, you know what we do: active stretching, assisted stretching, passive stretching, and prolonged elongation using positioning, splinting, orthosis, standing devices. This is the these are all the muscles to be stretched, and then these are all the range of motions to be performed. As I said, all joint movements in full range, no resistance, less repetition, never overdo exercise. These 4 points will do. And then, see, as I said, one is these children, we work on physiotherapy, orthotics, respiratory management, and supportive devices, for as they get older. Orthotic management, few therapists who are not aware of this disease, what they do, when the child comes with a tight Achilles tendon, resultant of weak quadriceps muscle, and the quadriceps muscle is 3 minus, or even 3, the child has a difficulty in walking on full foot. They give the child AFO and advise the child to walk. That should not be, because that will further deteriorate the condition. Orthotics in Duchenne muscular dystrophy is mainly meant for positioning. It is not meant for mobility. Never ever ask the child to walk with AFO. That is not at all advisable. Only it gives stability, provide comfort, and it reduces the contracture issue, and also it helps in prevent and correcting deformity. There is no evidence for any child to walk with ankle foot orthosis or above knee caliper or below knee caliper, whatsoever it may be. Maybe once when the child has difficulty, you can help them in standing, but don't attempt the child to walk with AFO or any other caliper. So as I said, nighttime sprints to slow the development of contracture, CAFO, AFO, spine brace, wheelchair. The problem with the spine brace is, these children, as with this disease progression, when their life is more on wheelchair, they tend to develop mild scoliosis, ranging from mild to severe scoliosis. But if a child has been diagnosed with muscular dystrophy, if as a physiotherapist, when we spend maximum time with the patient, if you could able to convince the child and the parent about the usage of steroid regularly, it minimizes the disease progression. These children, if you could able to maintain with the proper medication, appropriate changing in the posture. If the child sits for more than 1 hour, ask the child to lay down using a recliner or in the bed, or give some lateral support. Till 16, if you could manage it, the severity of scoliosis is very, very less. If the child is not on proper steroid, again, what happened? The chances for the scoliosis is very, very high. Another is positioning, and instead of asking the child to sit hours together, if you advise the child on and off, try to use recline chair, lay down in the bed, that minimizes the chances of getting scoliosis. If the child develops scoliosis, the problem is, when the child is standing only, we have the access to measure the cob angle. Any angle between 0 to 15, spine brace may help. If the angle goes beyond 35, spine brace is a placebo, and unfortunately, in our country, very difficult to use a brace throughout the day. That will further have difficulty in breathing, as well as the child may not be comfortable with the brace. Next thing is option of surgery. Unfortunately, because these children, giving anesthesia is very, very risky. After surgery, the children has to be in the intensive care unit. The cost will be around 8 to 10 lakhs. Most of the people, they can't afford it. And also it is not covered in the insurance. What as a therapist you can advise is, explain about the nature of the disease, tell them to be regular with the steroid, ask them to change the posture regularly, and if possible, try to stretch the back by using one hand under the axilla, another hand in the pubic, in the hip region, stretch the muscle. That itself will do. And most of the centers, it is not advised to use spinal brace because of our the temperature and the difficulty in being on spine brace throughout the day. So as I said, daytime orthosis to be avoided because that will compromise the function. Second is, as I said, to maintain the muscle properties, stretching, range of motion exercise, positioning, and splinting. The next come is, because as I said, these children, as with their disease, there is a chance for developing any respiratory problem. What we do in our center, there is some evidence that all these children, we advise them to have a seasonal flu injection. Every year during the month of August, a new batch of influenza vaccine will come. Our clinician will insist the children to go for a regular influenza flu shot, so that will minimize the chances of respiratory complication. One. Second is, in the beginning stage, we use this incentive spirometry to do little bit of expansion exercise. Again, incentive spirometry, you don't advise the child to do 20-25 repetitions, just 5 to 10 repetition to maintain the lung, just to give some motivation. That's all. If you do too much of many repetition, again that will weaken the respiratory muscle. As the children grows, there is a chance for them to develop carbon dioxide retention in the lung. What we advise, ask the child to blow whistle in the morning time 5 times, because the carbon dioxide retention is more in the early morning time. We will advise them to blow out whistle or then balloon or whistle, whatever comfortable, at least 5 to 10 repetitions. That will try to minimize the retention of carbon dioxide in the lung. And for the expansion, they can use this incentive spirometer. And also, when the child grows, when the functional vital capacity, when the functional vital capacity, it goes down to 70%, what we do, these children got good control over the respiratory other centers. Dr. Marthu will accept. What we do, we teach them breathing using closed glottis, using the muscles of pharynx, so that what happens, this muscle exercise will try to augment the respiratory muscle work, so that it will be easy for the child to take more air. What the technique we use is glossopharyngeal breathing. Glossopharyngeal breathing or frog breathing, which is done under closed glottis. It doesn't require the effort of diaphragm and intercostal muscle. We will ask the child to do gup, 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 gup. So this will try to fill the lung and improve the functional vital capacity. Lot of study has supported people who does regular glossopharyngeal breathing. There is an increase in the FVC between 10 to 15%. So initially breathing exercise using spirometry for avoiding excess carbon dioxide retention, balloon or whistle. And as the child grows, then what happened, to augment the better, to get a better FVC, you add up glossopharyngeal breathing also. Properly position the child. The child should be allowed to lay on the sides. It is easy. And if the child could be able to lie on prone, that is also better. That will try to aerate the lung in a better manner. This positioning will help the children to have a better pulmonary function. Next, when one is we are starting with simple spirometry. Second is we go for the glossopharyngeal breathing. But as the disease progress, there will be further deterioration in the diaphragm, intercostal muscle, wherein it won't let the lung to expand fully because of the weak muscle. What present standard says, you can augment the breath by doing a breath stacking device. This green device is called a breath stacking device, which got a valve. It is a uniflow, single valve. It won't do backflow. It is not a double valve. It is a single valve. What all you need to do is place the mask in the child face, ask the child to take a breath, and you augment by pushing the ambu bag, which will try to give more aeration. Just like we inflate air in our two-wheeler or four-wheeler. This will try to augment the lung expansion in a better manner, wherein lung elasticity also will be retained. This is another boom in the management of pulmonary management of children with Duchenne muscular dystrophy. It is being practiced globally in Europe and Western country. All the child will be given this single valve ambu bag or breath stacking device, they used to say. These two will help in improvising the pulmonary function of the children. Okay, two. The third is, with all this means, as the child grows, slowly the child will go for further deterioration in the pulmonary function. When a parent come and say, sir, child, there is a snoring when my child sleeps. Morning when he gets up with a severe headache. There is a mood swing. My child is having a dry mouth. Then we have to suspect child is suffering with hypercapnia. So what we do, see, the hypercapnia due to some other reason, like any COPD, chronic COPD, there are a lot of ways to manage. Once these children, as there is a restriction of muscles, they were not in a position to blow out properly. What we do, to have an idea about retention of carbon dioxide, we do overnight sleep study. Because in sleep study, there are 3 models available. One is simple respiratory, second is with EEG, fourth is to measure the proximal limb movement. We do the basic level respiratory channel. Overnight, whatever time the child sleeps, it will record the sleep pattern, and the next day we will have the report. For a child below 17, the normal apnea-hypopnea index should be 1. We can accept up to 5. If it is more than 15, 16, then the child has to be monitored properly. We will refer the child to a pulmonologist. They'll take an X-ray. They will do an echo to find out the cardiac function. Then what we will do, we will try to contemplate giving a child, because see, when the child is on steroid, when the child has deformity, when the child sleeps on supine, there is a high chance for the tongue to get dropped that will further hinder the air to go from the nose to the lung. What we do initially, we advise the child to be on the sides, if possible prone. In spite of that, if the problem persists, a simple ABG also will relieve about the PCO2 retention. What we do, we give BiPAP machine. BiPAP machine is bivalvular positive airway pressure, wherein we preset the inspiratory and expiratory pressure, and this child will have a better sleeping pattern, better quality of life. We have a very good experience by trying with more than 40 to 50 children, and we got excellent data about that. In spite of that, BiPAP, when the respiratory muscle is very, very poor, the child could not able to take proper oxygen. We will try to augment mild 1 or 2 liter of oxygen along with the BiPAP, so that the child quality will be better, child will be fresh, cheerful throughout the day. So this is BiPAP. So this is the type of management. What because the thing is, like with respect to muscle stretching, positioning, range of movement. With respect to tightness, orthotics, what type of orthotics are being prescribed, I told. With respect to pulmonary, stepwise, start with the deep diaphragmatic costal expansion, then simple incentive spirometer, then go for glossopharyngeal breathing, next go for single valve ambu bag, next level go for BiPAP, next level, in spite of that, there is no proper oxygen, add oxygen concentrator so that the child quality is better. One I told. Second is to prevent posture, frequent changing of posture, not allow the child to sit for a longer time on the sides and use a reclining chair or a wheelchair. So after, in spite of that, when the child lost the ambulation, then we advise appropriate wheelchair for them, again stretching, splints, and then spinal support. We always advise on customized wheelchair, because not a normal wheelchair won't fit for these children. Most common problem is lateral tilting. We give lateral support to keep the child in a straight position. We ensure that we try to ensure the child maintain 90 degree in the food by giving a proper foot rest, and we advise a proper hand rest so that the child won't droop down. And we provide a table for the child so that he can do activities of daily living, because when the disease progresses, the child will lose movement in the shoulder, elbow, only hardly he can use the finger. Whatever movement they can do, that they can do. And gradually we move the children to electrical wheelchair, and they are very smart enough to handle the joystick for their mobility. So at the end of my lecture, I want to stress 2 things: no strengthening exercise, and also eccentric exercise. Some parents say, no, I'll ask my child to go down in the ramp. I ask my child to do this trampoline, and I ask my child to do too much of abdomen exercise, because the child develop lordosis, the excessive lordosis. Lordosis is not weakness of the muscle. It is because of the weakness of the hip extensor, strong hip flexor. It is going on anterior tilt. So never attempt to strengthen the abdomen muscle to correct the lordosis. That will further have an ill effect on the child progression. And earlier they used to say, we use this positive expiratory pressure device like Acapella or Aerobica, wherein this is used for children with cystic fibrosis, bronchiectasis, to bring the sputum out. In this case, it is not advisable, because again, this resistance exercise will weaken the respiratory muscle. Don't do any physical activity beyond fatigue. That is not advisable. Okay. So in the short 1 hour, this is the maximum. I can just summarize it. Treatment is aimed to control and manage the symptom. Muscle exercise help because being inactive can make the disease worse. Physiotherapy can help maintain muscle strength and flexibility. Physiotherapy aids such as braces or wheelchair can help give more mobility. These measures aim to give people with Duchenne muscular dystrophy a better quality of life. Okay. So this is in brief about the present standard of care. If you have any queries, you are most welcome to ask me.
Now the forum is open for discussion. Participants, if you have any queries or questions, you can raise now. Let me check in the chat box, sir.
Yeah.
So one question is, whether
Yes, sir.
muscular dystrophy can be identified during pregnancy period?
Sir, one is, see, basically this is among various type of muscular dystrophy. Duchenne muscular dystrophy is X-linked disorder, wherein female is the carrier. If a parent comes and tell doctor, I had my brother when I was young, slowly the child become immobile and he died in his 20s now, then what doctor do? They do a genetic testing to find out whether she is a carrier or not. If she is a carrier, then definitely it has to be stopped. Second is the second child, once when the child was diagnosed with Duchenne muscular dystrophy, second child, if they are planning, they have to definitely go for carrier analysis. The carrier analysis will definitely reveal whether that the child is going to have a muscular dystrophy or not. We advise them for any alternate method. That is one, sir. And if that mother have a male baby and a girl baby, male baby may be victim of Duchenne, but that girl may be muscular dystrophy. That she may be a carrier, sir, the next generation. We can identify.
Thank you, sir.
Yes, sir.
So
So with all the means, because yes, sir.
Yes, sir. You can continue, sir.
No, with all these means, we are trying to minimize the incident, because having a child with muscular dystrophy is very difficult, because we see the difficulties following these children for 20-25 years. What we do, you see, one is we are in the process of setting up registry. We already made standard of care. We also work with all